Hey everyone, Ryan here, and welcome to our last video in the Pediatric Dentistry series. So this one is going to be all about child behavior in the dental clinic. So first, let's talk about some big picture, big categories for child behavior. We have the cooperative patient, who is communicative, comprehending what you're doing, and just willing and excited to be there. There's minimal apprehension about what you're doing and why they're there. The next big category are the potentially cooperative patients, and the key word being potential. So they are capable of appropriate behavior, but can be, and in these cases, are disruptive, unfortunately, in the dental setting. So these are the patients that can really go either way, depending on how they're feeling that day and how you deal with the situation. So there are a lot of different personality types that the board exam does like to ask about. So let's go over these now. We have the defiant patient. So this could be at any age. Typically, as some of the test materials out there will describe them as spoiled and stubborn, and they do not like to be advised by adults. The uncontrolled patients typically, on average, are 3 to 6 years old, and they like to have these tantrums. They make a scene, an emotional outburst during, before, not as much after the dental procedure is occurring. Timid, again, that 3 to 6 year old age range, and they might hide behind the parents, using them as sort of a shield, and may deteriorate into this uncontrolled tantrum category. The tense cooperative patient are 7 years or older on average. They are a white knuckler, which means they grab the armrests of the dental chair so tight that their knuckles start to turn white, and they want to behave, but they're just very nervous about what's going on. So it's really good to kind of talk to them and describe what they're feeling and what you're about to do. The tell, show, do method, always a good tool for a lot of these kind of patients. And lastly, we have the whining patient, just this continuous whining. There are usually no tears involved. A lot of it can be to get the parent's attention and sort of garner that affection from the parent. So these are just some big picture examples of potentially cooperative patients. And then we have, of course, the uncooperative patient that's just not communicative, not comprehending what you're doing, and not willing, and certainly not excited to be there. And some examples are just really young infants, 2-year-olds even, the terrible twos you might have heard of, or someone who has a developmental disability can also fall into this category. So, Dr. Frankel published a study back in 1962 with this behavioral rating score that ranks children from a scale of 1 to 4, going from worst behaved to best behaved. So let's go through these one at a time. We have 1 is our definitely negative. This is the patient who exhibits refusal of treatment, forceful crying, fearfulness, or any other overt evidence of just extreme pessimism and distress. Does not want to be there and does not want to cooperate at all. 2 is having some sort of negative resistance. So this would be reluctance to accept the treatment, being generally uncooperative, and some evidence of negative attitude, but it's not as pronounced as we saw in the 1 scores. 3, now we're starting to be on the positive side. So there's acceptance of treatment, but there's some cautious behavior at times, but they're generally willing to comply with the dentist, although with some reservation, but the patient does follow the dentist's direction cooperatively. And then 4 is our definitely positive. They have a good rapport with the dentist, they smile, they laugh, they like to be there, they're interested in what's going on, and they're just generally enjoying being there. So those are the most enjoyable to work with, and that is the Frankel 4 score. And children generally improve as they get older, so they tend to be uncooperative as an infant, the terrible twos, and then generally they become more cooperative and willing to comply if they have a generally positive experience early on in life. So let's go through some pediatric dental terms that you might find on some progress notes. So anticipatory guidance refers to age-appropriate counseling for patients and their parents focused on prevention, focused on not getting cavities, not having gum disease, getting fluoride and sealants and that sort of thing. So talking about good oral hygiene methods with the parent, talking about a healthy diet for their teeth and that sort of thing. That's what anticipatory guidance is all about. So the first dental visit should be at 1 year old. 1 year old patients should actually are encouraged and recommended to come in for their very first dental visit. And there's limited but strong evidence that early dental visits make a difference for children with disease and at high risk for dental disease. Familiarization. This refers to a no-treatment dental visit with an emphasis on introducing the dental setting and common instruments. So this is really good for patients who might be like tense cooperative or potentially just all the way uncooperative. Just having them come to the office, get a feeling for what the dental office is like, how it sounds, how it feels, how it looks, and not doing any dental treatment at all. Just having them come in, tour the office. It can be kind of fun, maybe even get a prize, and not do any dental treatment or not even an exam. Just having the patient kind of get familiar with what's going on. So that can be a really nice method to help with that initial nervousness. Functional inquiry is just a fancy way of saying a questionnaire or interview with the patient's parents, and it allows you to learn their chief complaint and estimate that behavior, what they might be like going down the road. You can usually get a pretty decent idea from that first interaction. All right, this is great for the board exam. I see it come up all the time, the knee-to-knee exam. So if the board exam asks you, a 1-year-old patient comes in for an exam, how do you conduct that exam? Your answer is going to be the knee-to-knee exam. This is for infants that are less than 2 years old. That's what the word infant means. And clinician and parent are in a knee-to-knee position, like we see here, with the child's head in the dentist's lap and the legs wrapped around the parent. And the parent can also help just keep their arms nice and still while they're having the exam. So this is a great method for kind of keeping the child relatively comfortable. They can look at their parent while they're going through the exam, and it's over nice and fast, and then they can give their parent a nice hug when it's all done. So knee-to-knee exam, I see it come up all the time. Definitely remember that. All right, so 5 domains of pediatric patient management. We have the physical domain, which is the papoose boards, the belts, the tape to hold the patient down. Not always the best thing to do, but sometimes it's the necessary thing to do. There's pharmacological methods of management, and so we'll talk a little bit more about that. There are reward-oriented things like reinforcement, and then the opposite is the aversive domain. This is punishment, and linguistic domain is all about communication. These things might sound pretty familiar if you watch the patient management series. I actually went into a lot of depth on those topics, so put that on your list. I have a couple on health behavior change specifically. I think it's the 3rd video in the series. That's going to be really good into diving more into depth on these things if you want to learn more about it. So typically for mild forms of intervention, we're thinking about doing nitrous oxide. For moderate, we're thinking for like moderate behavior issues, we're thinking more oral sedation. And for severe, we're thinking more IV sedation or general anesthesia. And you can also do something like animal-assisted therapy. Having a dog or something that has been trained in the office can also help put some kids at ease. So a lot of different methods for helping the kids out. Behavior shaping, again, we talked about this a lot in the patient management series, but we want to slowly develop behavior by reinforcing successive approximations to a desired goal. Basically, what this is saying, a great example is we ask the kid to open wide. They only open a little bit, but that's still kind of close to what we want. So we still want to positively reinforce them. We want to say, good job, you're doing great. Can you give me a little bit more? And just helping them along. Reinforcement should always be immediate. This is true for any feedback. It should be immediate and specific to the desired behavior. So don't just say, good job, say, great job opening your mouth. Can you do it a little bit more so they can know what you're expecting and know how to help if they're cooperative. Aversive conditioning. It's a little bit more, contradictory, I might say. This is punishing with the purpose of extinguishing or improving negative behavior. This is not recommended for the timids and the tense cooperatives. These are some of those personality traits or types that we were talking about before. Voice control, speak in firm tones, be firm with them. This can be difficult if maybe you're not a parent yourself, and I found it difficult personally just to talk to somebody's kid in a more firm voice, but sometimes that does help. And the hand over mouth technique is tested on the board exam. This is where you gently place your hand over the patient's mouth to gain their attention. If done well, it's perfectly fine. Again, it's one of those more contradictory things. Some people debate whether or not it should be used, but I did include it because it's tested on the board exam, particularly useful for those uncontrolled type of patient behavior, the tantrum patients. All right, so let's talk about some specific behavior disorders. Our first one is ADHD, which stands for attention deficit. That's our inattentive. And hyperactivity disorder. It's more common in boys than girls. That does come up on the board exam. It's a nice quick fact to know. Most commonly first appears between the ages of 3 and 6. That's when it's most commonly diagnosed. And the 3 most common psychostimulant medications for ADHD are methylphenidate, atomoxetine, and amphetamine. And these actually do pop up on the board exam, hence why they're in red text. I was kind of surprised to see that, but they are tested, so that's a good thing to know. Also interesting to know about these 3 is that all of them have the same side effects: nausea, dry mouth, and even some hypertension. So similar side effects, similar mechanism of action. Next, we have the autism spectrum. This is a condition related to brain development that impacts how a person perceives and socializes with others. Spectrum, in the name autism spectrum disorder, refers to it having a wide range of symptoms. So it's not so much if you're mild autism or severe autism, it's more about just this broad, wide range of possible things that someone that has autism might behave in these ways. So what's tested most commonly on the board exam is that they demonstrate some sort of repetitive behavior. This could be repeated body movements. They ask the same repeated question multiple times to you, and this heightened sense to light and sound. So they could be hypersensitive to sound from the suction or from the handpiece, for example, or maybe the bright light that you're using at the dental chair, and they might need to wear some sunglasses. So those are just some examples. Again, not everyone with autism will have these behaviors, but these are just some of the more common ones that are tested on the board exam. All right, local anesthesia in children. Big thing to know with this slide is that 4.4 milligrams per kilogram is the recommended dose of anesthetic. This is different than for adults, which isn't necessarily based on weight for the recommended dose. So this is specific for children. So really important to know that. And innervation, the inferior alveolar nerve, posterior, and you guys know all this stuff. We've talked about this in the previous videos, so I will skip through some of that stuff. All right, nitrous sedation in children. So we talked a little bit about nitrous sedation before, but I just want to go over some of the specifics with children. So the protocol here is to fill the bag with oxygen first, place the hood on the patient's nose, and then have a flow rate of 4 to 6 liters per minute. We increase the nitrous concentration in 10% increments, starting from 0 and then up to about 30, maybe max 40%, whereas in adults, I usually go to 50%, so it's a little bit less for children. Nausea is the most common complication. This is true for adults as well, tested on the board exam. And diffusion hypoxia refers to the phenomenon where the lungs fill with nitrous after it's stopped. So once you shut that nitrous off, the lungs will keep that nitrous oxide in their capacity. So you always want to give the patients 100% oxygen for at least 5 minutes to flush out that nitrous oxide from the lungs. Contraindications. This is really important for the children. We want to avoid nitrous sedation for anybody less than 2 years old. So any infants should not be using nitrous sedation. If they're uncooperative, that's not going to work because they're not going to want to keep the mask on and it will just be completely ineffective. And if they're having some sort of wheezing episode, they have a respiratory condition that's causing this wheezing, nitrous sedation is not the most prudent idea. Now, I wanted to include, though, that mild to moderate asthma is actually okay. Asthma alone is not a contraindication for nitrous sedation. And probably should have that in red text because I have seen that on practice questions multiple times. So asthma is not a contraindication. The 4 plateaus of nitrous sedation or stage 1 anesthesia are paresthesia, vasomotor, drift, and dream. So Dr. Karnow in 1969 described these 4 plateaus of the first stage of anesthesia with nitrous oxide. The first 2 of these, that's tingling and warm sensation, are over within just a few minutes. But the drift and dream plateaus last for much longer than that. They can actually be maintained safely for a couple hours if that's needed. And so these 2 are your desired levels of sedation for the child. Particularly drift is where you want to be. It's kind of where they feel like they're floating on the clouds. Dream is where the eyes are closed, the jaw sags. If you ask them a question, they're kind of more likely just to move their body around rather than vocalize and answer. So either of those are perfectly fine and safe plateaus for nitrous sedation. So using fluoride for children, this is straight from our patient management series again, so just another review. Fluoride for children should be prescription only, and there should be used for children that are at risk for caries who live in non-fluoridated areas. And a lot of it just depends on, or the method depends on the age of the child, and the dosage can depend on the amount of fluoride they have, in their typical diet, water, etc. And prescription, we're only going to be offering to somebody who's living where the water is not fluoridated. So if they're less than or equal to 3 years old, we're doing fluoride drops because they're going to have difficulty chewing and swallowing tablets. Once they get over that hump of 3 years old, we can do tablets and lozenges. And then over 6 years old, they develop that oral musculature to be able to rinse and spit out this fluoride mouth rinse. All right, how about thumb sucking? So we're kind of off of the topic of child behavior, but these are some really important miscellaneous high yield facts for pediatric dentistry that I did want to include in this series. So thumb sucking is very common up to age 3. There's not really a need to intervene anytime before that. That's totally normal. And it depends on the time per day, the duration, and the intensity of the thumb sucking habit, what kind of effects it might have on the dentoalveolar apparatus. So its effects on the arches are increased overjet, anterior open bite, maxillary constriction, and posterior crossbite, which is a side effect of this maxillary constriction, which we can definitely talk more about in the orthodontic series. And so intervention with some sort of appliance is recommended by age 5 or 6 if the habit has not been stopped by then. The thing with this appliance therapy, which I'll talk about in just a second, is that the child really has to want to stop. If they don't want to stop the habit, this is not a good idea because they're going to feel like they're being punished and they're going to be mad at the parent, they're going to be mad at the dentist, and it's not going to be a good situation. So the patient really has to be on board and really wants to stop. Typically that will be the case at this age because they're going to start to go to school and they don't want to have this habit anymore. So something like this can really help them. So the crib appliance is shown on the left. This is a stainless steel fixed retainer. It's banded on the molars, and it has this wire that holds this crib part in the anterior palate region. So that can just remind the patient not to stick their thumb up at the roof of the mouth, and in most cases just prevent it completely, inhibit that thumb from getting there in the first place, and then they kind of lose that comfort of having the thumb there. The bluegrass appliance is a little bit less used, but it has this, again, it's a fixed appliance, it's banded to the molars, and it has this acrylic roller, again in the anterior palate region. You could probably get your thumb around there, but the point is to just kind of have your tongue roll this thing and have it be a reminder not to be sticking your thumb to the roof of your mouth. So these reminder and preventive appliances can really help to break that habit. All right, another high-yield miscellaneous fact are the natal and neonatal teeth. Natal teeth means that they're present at birth. Neonatal means that newly after birth, they erupt within the first 30 days. So remember, our first primary teeth should be coming in at 6 months. 30 days is super early, but it can happen. The most common to be affected are the primary mandibular incisors, which are the first teeth to erupt anyway, so that makes sense, that they're just a little bit ahead of schedule. Riga feed disease refers to a baby tooth or baby teeth, particularly these mandibular incisors, right down here, that cause this nasty ulceration on the ventral surface of the tongue. So there are other manifestations of this, but basically these teeth really irritating this young oral mucosal tissue, and it forms this massive ulceration on there. And so what you can do is smooth those incisors or just extract them completely. And this may cause some nursing difficulties, as you could imagine. So how I remember this one is that Riga feed, it's spelled F-E-D-E, but pronounced F-E-E-D. Riga feed may cause some difficulty with the baby's feeding, and that's how you can help remember that. And we're going to finish up by talking about early childhood caries, which almost certainly will pop up on your board exam to some degree. It's also called baby bottle syndrome because affected children often are put to bed with a bottle full of milk or some fruit juice with a ton of sugar in it. ECC is a form of dental decay that affects the primary teeth of infants and toddlers, and it develops on two surfaces that aren't usually at high risk for caries. So we're talking about labial surfaces of the maxillary incisors and the lingual and buccal surfaces of the maxillary and mandibular primary molars. These are all primary teeth that we're talking about here. So from our, I believe, epidemiology video and the patient management series, we talked about DMFT. That's an index that measures decayed, missing, and filled primary teeth. So any DMFT, any amount of decay on a patient younger than age 6 is diagnosed as early childhood caries. So any primary teeth that have cavities, you got ECC. Breastfeeding before bed should be stopped after the first primary tooth erupts. So that's another thing to help prevent the occurrence of ECC. Less sugar. We don't want that sugar resting on the teeth while they're sleeping. Other causes of ECC or contributing factors could be a patient who has frequent constipation. They might be consuming a lot of fruit juice to help relieve that, which can have a lot of sugar in it, cause ECC. Or even a patient with a lot of ear infections. I had a ton of ear infections as a kid growing up. I took a bunch of antibiotics, and a lot of the liquid forms have a ton of sugar in them. So this can also be a contributing factor to ECC. But of course, if you brush your teeth well and do a nice job with your diet the rest of the time, then that's not necessarily a concern for you. So, recommendations for ECC. We talked about breastfeeding before bed should be stopped after the first primary tooth erupts. Other things you can think about: infants should drink from a cup as they approach age 1. The first dental visit by age 1, we talked about the importance of, as soon as those first couple teeth come in, teeth are vulnerable to cavities. So having them come in, at least get familiarized with the dental office, or have a full-blown exam or anticipatory guidance. All of those things are good to have early on. And a smear of toothpaste before age 2, and the pee of toothpaste between age 2 and 5. All right, so that is it for the Pediatric Dentistry series. I will have a bonus video with 15 practice questions like we've always done, so you can test what you learned in these last couple of videos. But that's it for this one, guys. Thank you so much for watching, and please like this video if you enjoyed it, and subscribe to this channel for much more on dentistry. If you're interested in supporting me and the channel and what I do, please check out my Patreon page. Big shout out and thank you to Michael Raja, Reb Boyd, Leonella Bunger, Zahir Anani, Riha Wadwa, David Jaden, Isabella Caldas, Ali Benjir, Badir Hefnawi, and all of my patrons for all of their continued support. You can unlock extras like access to my video slides to take notes on, and practice questions for the board exam, so go check that out. The link is in the description. Thanks again for watching, everyone, and I'll see you in the next video.